So as people are still logging in right now, we'll go ahead and start with some introductions. You all can see what we're talking about today: advances in the understanding of etiology, evaluation, and management of neurotrophic keratitis. And so my name is Walt Whitley. I am the Director of Professional Relations and Education at Virginia Eye Consultants in Norfolk, Virginia. I work at a large tertiary referral care practice, and I oversee the dry eye clinic and ocular surface clinic within the practice, and get to do this webinar today with a short-time, long-time colleague, Dr. Stephen Flugfelter. Stephen, you want to introduce yourself?
Yeah, sure, Walter. It's a pleasure to do this webinar with you. I'm Steve Flugfelder. I'm a clinician scientist at Baylor College of Medicine in Houston. My practice focuses on primarily on ocular surface and corneal diseases, and I had quite an extensive experience treating and diagnosing neurotrophic keratitis. So welcome to all of you.
And today's webinar is supported by an independent educational grant from DOMPE. And so for those of you getting credit for this, the various organizations that are certifying these credits, and so this is going to be for CE. Thank you to MedNet and Medco for putting this program together. In order to obtain your CME or CE certificate, please attend the webinar completely, after which you'll be able to participate in a brief evaluation and download certificate using the link displayed at the end of the program. Please complete this by September 1st, 2025. The speaker disclosure or disclosure policies, all faculty, planning committee members, individuals that are in position to control the content were required to disclose the relationships with ineligible companies, and ACCME requires us to disqualify from involvement in the planning and implementation for accredited continuing education program. We're all very familiar with this. These are our disclosures. Here's my disclosures. I work with several different companies within the ocular surface disease space, whether serving as a consultant or doing some clinical research. And then Dr. Flugfelter, those are his disclosures as well. And then for the planners and managers of Medco and MedNet, and the peer content reviewers for this activity have no relevant conflicts of interest to report. Disclosure of unlabeled use. And so there's many things that are on label by the FDA. There may be some discussions of some off-label uses. The planners of this activity don't recommend the use of any agent outside of the labeled indications. Opinions expressed in this activity are going to be Steve's and my own, and we'll mention if it's on label or off label. And then disclaimers: learners have an implied responsibility to use this newly acquired information and to enhance patient outcomes. And that's why we do these type of webinars, to see, hey, what's out there, what are some of the things that we've all learned clinically, but also how can we share that with each other, all for the best interest of our patients. There is a Q&A, and so Steve and myself, we're both going to monitor those Q&A questions. And so if you have any, please don't hesitate to use that Q&A box or the chat box, and one of us will kindly interrupt each other and keep this conversation going. And that's what we want it to be, is a conversation. We will have time for Q&A at the end, and so we will be able to answer all of your questions. So let's talk about what our objectives are today. And so I'm going to start off to summarize the etiology, pathophysiology, recommended screening and testing procedures used to diagnose neurotrophic keratitis. And then Steve's going to talk about the efficacy and clinical utility of current and emerging treatments for both early and late stage NK. And so that's what our discussions are going to be about. Here's our agenda. We're going to start with the pre-test question, and it is going to be a polling. I'll go into my section for about 30 minutes, and then we'll transition over to Steve's, and then we'll to talk about the treatments, and then we'll go over the Q&A, as you can see here. So here's our pre-test clinical vignette. And so here is an 84-year-old white male who presents for ocular surface evaluation. He has a history of dry eye in both eyes, blurry vision, left eye worse than the right, difficulty focusing at all ranges, and feels like there's film over the left eye. He frequently feels a foreign body sensations and tearing, currently uses preservative-free artificial tears 4 times a day, uses combination neomycin, polymyxin B, and dexamethasone twice a day. Ocular history has had various treatments for ocular surface disease, whether it's the 4 sessions of IPL, 4 sessions of radiofrequency. He's tried and failed cyclosporin and lifitegrast, has had cataract surgery and lid procedures. You can see the medical history: rheumatoid arthritis, hypertension, kidney stones, and the various medications that the patient's on. If we look at the clinical findings, utilize the speed questionnaire, 18 out of 28, and 28 is the highest score that you can get, looking at the severity and frequency of patients with dry eye disease. Best corrected vision you can read. But if we take a look at the slit lamp, looking at the lids, looking at the 1+ SPK and the 5-second tear film breakup time on the right, and then the left eye has about a 4-second tear film breakup time, but 3+ diffuse SPK. So based on the history and clinical findings, you suspect NK. And so which would be the most appropriate clinical test? A, corneal sensitivity, B, Schirmer 1, C, tear osmolarity, and D, matrix metalloproteinase. And so go ahead and click on your vote for what you think is going to be best. And I'll give it a couple more seconds here. And then we'll go ahead and get started into the presentations. And so advances in the understanding and etiology, evaluation, and management of NK. I mentioned my practice. We have 4 cornea specialists, numerous providers that do ocular surface disease. About 40% of my day is seeing patients with ocular surface disease. Here's my disclosures, but I like to start off with cases. And so here's a case. 51-year-old white female presents for a dry eye evaluation. Vision fluctuates throughout the day and eyes get very dry and red and scratchy. Has been using cyclosporin twice a day for 6 months. Lots of artificial tears, which every hour, which gives her the most relief. And she's had bandaged lenses in the past. You can see her ocular history, her medical history, and the medications that she's on. And so, just a couple of things that call out to me is vision. And so ocular surface disease, it does impact our patient's vision. And we've all seen this, where it's clear, blurry, clear again for our patients. We know blurred vision is the number one reason why patients come to us for even whether it's a vision exam or a medical eye exam. But tell me more. Is it always blurry? If it's always blurry, it's cataracts, refractive error. But if it fluctuates, we need to take a look at the ocular surface. Been on cyclosporin. We know cyclosporin works. She's been on for 6 months. We typically tell patients it takes about 4 to 6 months for it to work. But then artificial tears every hour. We know that there's over 2,000 components of the tears, and if they're putting lubricant and washing away a lot of the components of the tears, then what is that doing to the ocular surface? And so that's something that we can definitely discuss going forward. Looking at the speed questionnaire, the patient does have severe symptoms of ocular surface and MGD, so the severity and frequency of her condition. And so for any dry evaluation, this is something that we utilize. You can see the best corrected vision, the refraction. We do use tear osmolarity frequently within the clinic, and patient has mild hyperosmolarity. Anything above 308, or anytime there's 8 milliosmoles difference between the right eye and left eye, those are patients that we need to look at that tear. Are they too salty? Do they have the abnormal or imbalance within that tear film? Inflammation's positive. I check the pressures at the end, but you can see the slit lamp, 1+ telangiectasia, 1+ injection, dense SPK, and 0.2. And so here you can see any other test, looking at the tear meniscus. I don't do Schirmer's very often, but we do take a look at the tear meniscus. And there's various diagnostic tests that can do and measure this for you. But then corneal sensitivity, check the right eye was absent, left eye was reduced. So Steve, is there anything else or any comments you have on this case so far, or any other tests that you would include?
No, obviously the patient has a corneal epitheliopathy of some etiology. One thing that is kind of striking is that the patient has a lot of symptoms, yet the corneal sensitivity is reduced
Uh-huh.
and absent in the right eye. So that's kind of the disconnect that we see sometimes in stage one NK. That the nerves are kind of traumatized and they may be abnormally signaling pain impulses, but they don't feel anything mechanically.
Yeah, yeah. A great points there. And there is that disconnect. And so that's why it's not just about symptoms, it's also about the signs for our patient. And so if we take a look, the meibomian glands, I showed the patients, hey, these glands, they secrete the outer layer of the tears. But if we look at that surface, and this wasn't the patient, but we see that dense staining and the epitheliopathy that Steve just mentioned. It was in both eyes with reduced sensitivity in the right and or absent in the right, reduced in the left. And so when we look at ocular surface or dry eye, we know it is a multifactorial disease of the ocular surface, but these are the callouts: loss of homeostasis. Patients may have symptoms, tear film instability that leads to evaporation, that leads to hyperosmolarity, as we can see here, that could lead to the inflammation. And then also neurosensory abnormalities is part of the definition. And so, with the TFOS deuce 2, there's several callouts. Is anyone can have dry eye disease, but also that you have to treat both the lids and the evaporative component, but also the aqueous deficient, keeping inflammation in mind as well. And so many of you are familiar with that definition, but let's look at the cornea. Yes, I keep talking about dry eye, but the reason why we bring that up is because that was my aha moment. I've had numerous patients over the years that you've been treated for dry eye. In this case here, the patient was on cyclosporin for over 6 months, but still having the issues. And so taking a step back, is this dry eye or is this something else? But if we take a look at the corneal anatomy, we know that it's richly innervated, supplied by both the sensory and autonomic nerve fibers, comes from the ophthalmic division of the trigeminal nerve, both sensory and efferent functions. But there's mechanical, thermal, and chemical stimulation, which it can be perceived as pain. And so if we look at that feedback, and so we know the corneal nerves help maintain the corneal integrity. It does provide protective functions with the blinking and the tearing to replenish that surface, to wash out any irritants or whatever that can be affecting that ocular surface. The trophic support, promoting epithelial proliferation, migration, and adhesion, but then also for survival of those. But anytime we have a breakdown within that nerve, that's where we're seeing these signs that just aren't getting better in our patients. And there's numerous studies out there, and the one on top is looking at patients with glaucoma. And we know that patients that are on these preservative, typically it's going to be a prostaglandin, that this does essentially a detergent on that surface, decreasing that corneal sensitivity, which was found to be significantly decreased in dry and glaucoma patients versus the control. And the density and the number of the subbasal corneal nerves are also significantly decreased in dry eye and glaucoma patients compared with controls. If we look at the other study in patients with non-Sjogren's dry eye, mean corneal sensitivity was significantly lower as compared with the control group. But then those patients also had both structural and functional alterations of those subbasal corneal nerves. And so what's happening in dry eye and leading to NK is the sensory nerves may adapt to irritation by decreasing frequency and intensity of those action potentials. And so we know that those nerves get weaker, so it's going to take a stronger stimulus to get that any type of basal tearing or reflex tearing. And so corneal hyposthesia does play a role in the pathogenesis of tear deficiency. And so seeing that patient, anytime we see this, we need to start thinking, what is going on? Is NK, the NK needs to be in our differential for these type of patients. And so, Steve, how do you describe NK? I'm your patient. How would you describe that to me?
I think the definition, is a patient that has reduced or absent corneal sensitivity with corneal findings, just as you've shown with this patient.
Mhm. Yeah, and so telling those patients, looking at the definition here, decreased sensation, decrease or no pain that this patient has. Here we can see a patient with stage 2 NK where we're having that defect. Typically, that's going to be oval shaped, and we'll go into the various staging mechanisms. But here's the definition. It's a degenerative corneal disease, damage to the trigeminal nerve, loss of corneal sensation, breakdown of the epithelium, impaired corneal healing, and persistent epithelial defect that can lead to stromal melting and the perforations that patients may get. And so neurotrophic keratitis, we see this fewer than 65,000 affected in the United States, and it's classified as a rare disease. NK prevalence, has been difficult to determine, and many times it's because we weren't looking for it. Steve, what do you think about these rates? Is this underdiagnosed?
I think it's underdiagnosed. I mean, I think just like you mentioned, a lot of people in the two cases you showed, many people with chronic, what's considered to be dry eye, really have a neurotrophic component
Yeah.
to the disease. So
Yeah.
I think now that people are more aware of the condition and that they're checking corneal sensitivity on a regular basis, that they're actually finding more cases of NK.
Yeah, yeah. And you just mentioned corneal sensitivity. We're going to say that a lot because that's that test that allows us to determine, does this patient have NK? But the history is always going to be important as well. What have they been on, whether it's ocular, whether it's going to be systemic history or any previous surgeries. But the most common reasons for this is going to be the herpes simplex or zoster, as you can see the prevalence rates there, but then also post-surgical nerve damage. Looking at etiology, many different causes, whether it's infection, whether it's diabetes. We know that diabetes does decrease the peripheral nerve endings. We have our topical medications, just mentioned the glaucoma patients, iatrogenic, anytime the patient has had previous corneal surgery. And then you could read the other etiologies. And so it's just remembering for these patients. Glaucoma patient, we're thinking dry eye, do they have NK? Herpes, same, diabetes, but asking those questions, looking for signs for our patients. We know that there is endogenous growth factor, nerve growth factor, which maintains the corneal integrity. And so looking at the nerve growth factor, we know it plays a role in the function and stimulates the regeneration and survival of the sensory nerves. We know that that leads to the proliferation, differentiation, and survival of the epithelial cells, but then it also helps promote sensory-mediated reflex tearing secretion. And so what happens in NK is due to the impaired trigeminal corneal innervation, we're going to get decrease in lacrimation, decreased vitality of the cells, decreased repair, corneal edema, whether it's intrastromal or intracellular or stromal, but decrease within various factors of the corneal cells. And so the differential diagnosis is the loss of corneal sensation. We know neuropathic pain is going to be the opposite. And these are the patients that were intense pain and have severe symptoms, but we take a look that there's no staining. We're not seeing any reason why this patient would have that neuropathic pain. Overlapping features of NK or can lead to NK is going to be dry eye disease, contact lens related disorders, stem cell deficiency, toxic drug toxicity, but also mild chemical injury. And so, do you test for corneal sensitivity? Steve, is this part of your typical evaluation? I know you have a dedicated clinic. And so, are you doing this frequently?
Oh, absolutely. Now, every new patient that comes to us gets corneal sensitivity measured by two methods, the Cochet-Bonnet, and then we have a air aesthesiometer, the Brill aesthesiometer,
Mhm.
also.
Yeah. Can you talk about that Brill aesthesiometer a little bit? Because we just brought that into our clinic as well.
Yeah, it was FDA approved, I believe, last year. It's a non-contact device. It mounts on a slit lamp, and so The nice thing is obviously you don't have to touch the patient, and because I'm always concerned a little bit about the crochet bonnet, about how to sterilize the tip. It has 5 levels of sensitivity. We and others have found pretty good correlation with mechanical sensitivity, but one interesting feature of it is that some patients, just like the one you were talking about, if we increase the stimulus, they may report that the air jet is a little bit uncomfortable. So it does kind of pick up people that have like a heightened corneal sensitivity or even hyperesthesia.
Yeah, Shepard's been hiding that test for me. I can't wait to get my but he keeps it in his exam room. So typically what I do is I test corneal sensitivity with a cotton wisp. You can use a dental floss as well, non-flavored. But testing, is it normal? Is it reduced or is it absent? And then documenting that accordingly. And so that's been part of any ocular surface evaluation. One of the other tests that I've also added is going to be looking for incomplete blink or incomplete lid closure. And so looking at the core Blackie light test and taking the transilluminator, having the patient close their eyes and just illuminate the upper lid. And anytime you see that glow underneath the lashes, then we're suspecting patients that don't have a full blink or maybe they do have nocturnal like ophthalmos, but that's been something else that we've added. But for corneal sensitivity, central, main thing is test. If you haven't started doing this at all, just test the central. That's how you're going to be able to differentiate as within the ocular surface clinic. I know Shepard does all the various quadrants there, and I'm sure Steve does as well within his dedicated clinic. But if we look at the corneal sensation, it's greatest in the central cornea. It does drop rapidly as distance increases from the limbus, decreases with age, more sensitive in the temporal limbus than the inferior, and then reduction has been reported in both in diabetes type 1 and type 2. And so how you do it here, you could get some gloves. Steve mentioned earlier the where we even with the crochet bonnet and look and taking that filament, anytime you touch the eye, can you contaminate that eye? And same thing anytime you're making that wisp. And so gloving, putting some gloves on, making that fine tip. Is it normal? Is it reduced or is it absent? And so if we look at the classifications, the Mackey classification, this is what has been what most people have been using. Stage 1 is characterized by hyperplasia or irregularity of the epithelium that could lead to punctate keratopathy, corneal edema, neovascularization, and stromal scarring. Stage 2 defined by recurrent or persistent epithelial defects without stromal thinning. And stage 3, the stromal involvement leads to corneal ulcer, melting, and perforation. And so within our cornea clinic, we do see all of these. I do co-manage and collaborate with my cornea partners for those stage 2 and stage 3. But I think the biggest thing here is identifying early. And so if we can catch these patients earlier in the disease state, and Steve will talk about the various treatment options, that's how we optimize our patients' comfort and quality of our patients' vision. And so looking at stage 1, rose Bengal staining in the inferior palpebral conjunctiva, decreased here from breakup time. You can read all this, but this is the majority of patients that we're seeing or majority of patients that we have missed in the past. And so my aha moment again was those patients that have been on the various dry eye treatments. We know that lifitegrast works. We know the cyclosporin works. We know that if the patient's not getting any better, then we're thinking NK. We need to think about NK. I was part of a study group, and it was a couple of cornea specialists that you all know, and then also a couple of optometrists. And one of the things, the call-outs that we had is anytime patients have stage or grade 2 or higher corneal staining, consider neurotrophic keratitis. Yes, they may have dry eye, but we need to make sure that NK is within that definition. Stage 2, the epithelial defect, typically oval, as you can see in this picture and the previous picture that we showed, surrounded by loose epithelium. The edges may be rolled up, can have stromal swelling with the folds, and anterior chamber inflammatory reaction may be present. And then the stage three, the corneal ulcer, the stromal lysis or melting or perforation. And so, having the team in place, whether you're treating it, whether you're referring it out, make sure that, you have that phone a friend that you can manage these patients with. A couple of years ago, there was another neurotrophic keratitis study group that came out with a more precise classification, and the goal here is earlier diagnosis. And so, just like anything, the earlier in the disease state, the optimal outcomes that we'll have for our patients. And so, going from stage one is going to be mild, altered sensation without any keratopathy. Stage one, two, or three, that's going to have the best prognosis. But anytime you're having those persistent defects or corneal ulcerations, poor, or even, of course, a corneal perforation. And Steve, are you using this algorithm here, this staging, or using the Mackie?
Um, I like it, but I mean, I think the Mackie is fairly good, and some of these are just kind of gestalt. You know that you can kind of tell if somebody's a stage three and they have a desmetocel that you better get on it. So I think it's an advance, but I don't routinely like use this in the chart.
Yeah, we're typically using the Mackie within our practice. This is something from that diagnostic algorithm from the study group. If the patient presents with symptoms and a clinical history of NK, check corneal sensitivity. If it's present, then consider other causes. Is it dry eye, ABMD? If it's absent, then we're going to look more into NK and test that corneal sensitivity or other tests. For no, examine present signs. If present, check corneal sensitivity if they have that dense staining. And so going back to our patient, what I did, they did have hyperosmolarity. They had inflammation on the MMP9 test. And so I had them continue their omegas, start on hypochlorous acid. We know it's a antimicrobial, so try to keep the bacterial load down. Put the patient on loteprednol twice a day. And this was the on-label version, but of loteprednol. That neurotrophic keratitis bilateral, and we know that because we did test for corneal sensitivity, did have ocular rosacea, considered prescribed doxycycline, and considered IPL after risk benefits and alternatives discussed. Patient came back a month later, no significant change, constant itching, burning, finished meds as directed. And so if you recall, she was on cyclosporin 0.05%. And so I added the loteprednol, told her to use it 5 minutes before she puts in her cyclosporin. Anytime we're prescribing a steroid, check the pressure, check the nerve, because if anyone's going to respond, that's going to be a glaucoma patient. You can see the clinical findings here. The tear osmolarity did go down from 324 to both in the around 315. So the assessment and plan, though, is she did still have that diffuse staining that just is not going away. And so she's diagnosed with stage one neurotrophic keratitis bilateral. Discuss amniotic membranes. And typically we go with the cryopreserved membrane within our cornea clinic. Patient declined. So she stayed on the doxycycline. I said, well, we'll see. We'll just give it more time. I did increase to the 0.09% cyclosporin twice a day on this patient. I've had success with changing from 0.05 to the 0.09 with the newer delivery system, and came back in the end still having those issues and that staining that just won't improve. Those are patients with NK. And so I did already test the corneal sensitivity. So at this time, I said, hey, we're going to do an amniotic membrane, but also order Synergimin for our patient. Told her about the IPL that we'll consider, and then come back in a week for the cam removal. And so the key pearls when it comes to identifying and diagnosing NK is going to be the patient history once again. A patient, if they've been on dry medication, not getting better, perhaps they have diabetes, perhaps they've been on glaucoma drops for a long time, those are patients that I'm already thinking NK. Looking at those clinical findings, anytime I see grade 2 staining or higher, those are patients I'm thinking I need to test for corneal sensitivity. And so that is the take home is test for corneal sensitivity. You're going to find more patients that have NK than we think. And so this is my email. So if you have any questions here, please feel free to email me. I'm happy to answer them. And we're going to go into the post-clinical vignette, going back to our patient. I'm not going to read all this once again, but in the end, as you know, which test would be most appropriate to diagnose NK? And I pretty much already gave the answer, but you already knew the answer before this question came out. But just wanted to reemphasize the importance of the testing to identify those patients with NK. So corneal sensitivity, Schirmer, tear osmolarity, or matrix metalloproteinase. And so I'm going to turn this now over to Steve.
Walter, that was fantastic. A great review of the etiology and diagnosis. And let me share my screen. Okay, so we'll start off on this talk with a clinical vignette too. This is a 70-year-old female with a history of radiofrequency ablation of the left trigeminal nerve for chronic trigeminal neuralgia. And this procedure was performed about 6 years ago. She noticed blurred vision about 1 year after the procedure when diffuse punctate erosions were observed in the left cornea. She was treated with frequent artificial tears. And 6 months ago, she developed redness after rubbing her eye and developed a 3 by 2 millimeter non-healing central corneal epithelial defect with stromal neovascularization. And I'd be interested, a little later, we'll talk about that with Walter. A lot of these patients do get corneal neovascularization when the epithelial defect is persistent. And her vision was reduced to about 2200. This was initially treated with a bandage contact lens, preservative-free artificial tears, and because of the clinical inflammation, lodiprednol twice a day. The epithelial defect decreased in size to 1 millimeter, and then Synedrimin was started, and the epithelial defect healed within 2 weeks and has remained healed for over a year. And her visual acuity improved to 20/40 within 3 months. The question related to this case is what percentage of eyes treated with Synedrimin remain 1 year after treatment? Remain healed, that is. And the options are listed there: none, greater than 90%, 25%, or 40%. So my talk will focus on the efficacy and clinical utility of current and emerging therapies for NK. These are my conflicts of interest. I will talk about Synedrimin that's made by Dompe, but there won't be any commercial aspect of that. I recommend using a staged treatment approach based on the clinical severity that Walter talked about. And, he mentioned 2 different classification schemes, the Mackey classification, this scheme that's been around for about 30 years. And then the more recently expanded Ascaris classification that includes a epithelial defect with stromal haze in stage 4 and ulcer with perforation in stage 6. So for stage 1 that Walter mentioned, looks like dry eye when there's punctate epitheliopathy, and then stage 2 when the patients develop an epithelial defect, and finally stage 3 when there's a stromal ulcer and stromal lysis and even can lead to corneal perforation. For stage 1 NK, it's important to identify and address any ocular and systemic causes for NK, especially chronic type 1 diabetes. And there's been an association of NK in patients with proliferative diabetic retinopathy. My own experience is that if they can get their diabetes under control, it probably does help the NK. But beside the fact that it's obviously a life-threatening disease, so you want to be a good doc too. patients on chronic topical glaucoma therapies, especially multiple therapies with preservatives, are well associated with NK, as Walter mentioned, and then neurodegenerative conditions like dysautonomia and even Parkinson's disease. Virtually all eyes with stage 1 NK are dry, and the dry eye component should be treated. And then chronic epitheliopathy from any cause is associated with reduced density of the epithelial nerve plexus and sensitivity. As Walter mentioned, there's a dynamic relationship between the corneal epithelium and the so-called basal epithelial nerve plexus, where if the epithelium is healthy, it's going to support the nerve plexus. If it's not, then the nerve plexus will degenerate. For stage 1 NK, I take my initial approach is to try to stabilize and heal the condition. As I mentioned, address comorbid diseases and factors, definitely eliminate preservatives, which are primarily the ones found in glaucoma medications, treat their dry eye. I'm a big advocate of using doxycycline like Walter did, because it's a protease inhibitor and is well known to heal the corneal epithelium. And then over the past few years, I've actually been using topical insulin drops initially because they're easy to get and to formulate in the office. And then at the same time, I try to move to therapies that will support, protect, and even restore function for the long-term maintenance of these patients. And that would include Synedromin. As you heard, and probably in your own experience, it may take a few weeks or even a month to get Synedromin approved and shipped to the patient. So you have to do something in the interim. There's lots of reports of using serum or platelet-rich plasma. The variety of platelet-rich plasma that we use and actually formulate in our clinic is plasma-rich in growth factors, or PRGF. And then scleral lenses have become a big part of our management approach. Chronic therapy is probably going to be needed for stages 1 through 3. In stage 1, often, if you treat their dry eye and you initiate the therapies that I just mentioned, they'll eventually markedly improve or resolve, and then they may not need therapy chronically. But conditions that are not going to go away, like the trigeminal nerve ablation that I presented, or resection, genetic mutations like is found in familial dysautonomia, patients with really severe herpes zoster ophthalmicus or severe diabetic neuropathy. Patients are going to have those for the rest of their life. And so they're going to probably need to be on some sort of therapy chronically to treat the condition and prevent recurrence. So for stages 2 and 3, I utilize the same therapies that I mentioned for stage 1, plus consider, at least initially, using a bandage contact lens or the variety of amniotic membranes that are available. We try to avoid it, but botulinum-induced ptosis works fairly well, fairly quickly, and it's reversible. And really, I think most cornea specialists would reserve keratoplasty only for perforation, because results are not generally good with keratoplasty, and it may require a tarsorrhaphy, which isn't very good for long-term visual recovery. And then, and also to institute the therapies that support, protect, and even restore nerve function and morphology, which would include Synedromin, topical insulin, serum or platelet-rich plasma, scleral lenses, and then neurotization, if that's an option for you, if you have someone in your practice that does that or you can refer to. I'd like to go through each one of these therapies and just discuss their efficacy for NK. Amniotic membrane, as Walter showed, is a great initial option to stabilize by promoting epithelial healing and suppressing keratolysis. It releases a lot of growth factors and also has factors in it that inhibit protease activity. It provides growth factors and substrate to promote epithelial healing and attachment. So it's kind of like sprinkling fresh soil down into the wound. It's available in a variety of forms, from fresh frozen, self-retained, or sheets, and lyophilized as discs and sheets. And the efficacy of a single or multi-layer fresh frozen amniotic membrane for NK ranges from 55 to 89% for healing the epithelial defect at 1 month or longer. And as you can see, there are a number of different reports. And the multi-layer grafts can seal and heal small perforations. In our experience, if the perforation is less than 1 millimeter, there's a fairly good chance if you use multiple layers and even stuff one into the perforation and close the eye for a couple of weeks, that there's a good chance that it might heal that. There's been a lot of buzz about using topical insulin, and I'll show some of the rationale for doing that a little bit later. But studies have shown that 90% of stage 2 and 3 NK heal within 7 to 45 days with topical insulin at a concentration of 1 unit per ml. It was 18 plus or minus 9 days for stage 2, and a little bit longer at 29 plus 11 days for stage 3. And the best corrected vision significantly improved in both groups. And another study found that insulin significantly reduced the size of small epithelial defects over 20 days, with moderate epithelial defects showing slower healing, just like the previous study. And the recommendation is to use a regular insulin, either Humulin R or Novolin R, that's diluted in BSS. So what we do is we take 15 units of insulin out of the bottle and inject it into a bottle of BSS, which is 15 mLs, and we ask them to keep that in the refrigerator, and it's good for up to 30 days, and then we refresh it. One bottle of insulin actually has a shelf life of about a year if it's kept refrigerated. Synedgermin is the only FDA-approved therapy that's actually approved for stages 1 through 3 NK, and it may take weeks or longer for approval by the carrier, so plan alternatives for initial stabilizing therapy. After 8 weeks of therapy, almost 70% of Synedgermin, compared to 29% of vehicle-treated eyes, healed to less than a half a millimeter in diameter, and complete healing was observed in 65.2 compared to 16.7%. And I was fortunate to serve as the PI for that study, the FDA registration study in the United States. And in the European registration trial, the effect was found to be durable, with 96% of corneas remaining healed at 1 year. And that's been my experience too. And corneal sensitivity has been found to increase, neovascularization decrease, and visual acuity improved in 11 treated eyes in a large case series. These bar graphs show that the complete healing in both the EU and the US registration trials, with the blue bar being the Synedgermin and the salmon colored bar being the vehicle. It's amazing. The results were virtually identical, which has also been shown in other subsequent phase 4 treatment studies, with about 55 to 60% healing at 4 weeks, and around 70% healing at 8 weeks. So it's pretty consistent findings, fortunately. And these are just photographs of one subject that was in the clinical trial through 8 weeks of the Synedgermin trial, starting off with this classic oval-shaped paracentral epithelial defect at baseline, and then you can see that the defect became smaller and finally healed by 8 weeks. But there was also a accompanying decrease in stromal haze, which has also been reported. So many of you, in your experience, I'm sure you've learned that if you heal the epithelial defect, the stroma will not only remodel, but often the haze will improve. So the visual recovery may continue over months or even years. These are the pooled adverse events in the phase, well, it was a phase 2 approval trial for Synedgerman versus the vehicle. And you can see about 16% of patients had got eye pain versus only 8% in the vehicle. And in my experience, that's really been the number one side effect or adverse event that I tell all patients that about from 1 to 3 weeks after they initiate Synedgerman that they may experience a mild eye pain, not to be concerned about that it usually will recover over time. And then there was some other minor adverse events. Walter, have you had that experience too?
Yeah. For patients, anytime they're on the Synergimen, yeah, we have noticed that patients they do get that eye pain, but I often tell patients as you're on it, when you start to feel it more, that means it's working, is what I tell patients.
Yeah, exactly. Yeah, that's a very good point. So they know that it's starting to work. And then, I had mentioned both serum and platelet-rich plasma. Studies have shown that 20% autologous serum healed 71% of epithelial defects at 6 weeks and 92% at 12 weeks. And then one study from Spain showed that the PRGF healed 97% of epithelial defects at 11 weeks. It's now known from work done by our group and others that one of the predominant immune cell types in the cornea are what are referred to as tissue resident macrophages. And you can see on the right side here, this is the basal nerve plexus, and the green stained cells are these tissue resident macrophages in there. They surround the nerve plexus. But interestingly, one of the major factors that those macrophages produce is insulin-like growth factor 1, which is like insulin, but actually is about 1,000 times more potent than insulin. And it binds to receptors here, the green receptors that are found in the basal corneal epithelial cells. So the immune cells support both the nerves and the basal epithelium. And interestingly, platelet-rich plasma is found to stimulate the differentiation of those resident macrophages. So that may be one of the ways by which it works. I think those resident macrophages also probably produce NGF too.
Hey, Steve,
Many of you may
can I ask you a question on that last slide? Because I
sure.
get this question a lot. We do use autologous serum within our practice and have a couple dozen patients on it. But I guess my question is, are you going to PRP mainly now? Where does autologous serum fit in? Are you going to higher concentration first on autologous serum before you do a PRP?
I used serum for many years, and I think it works pretty well. But probably about 10 years or more ago, we switched to platelet-rich plasma. That was initially made by a local blood bank, but we've started using kits in our office to prepare it. So we prepare it ourselves, and pretty much now we just use that because the studies have shown that it is more efficacious, and we've had that experience too.
Okay, thank you.
You're welcome. So as I was mentioning, I'm sure many of you utilize scleral lenses, and if you're not, I would highly recommend it. That is, we talked about certain patients are going to need chronic protection of their cornea from their underlying condition. And the efficacy of scleral lenses was initially reported to heal persistent corneal epithelial defects in the early 2000s by Perry Rosenthal, who kind of resurrected scleral lens technology in the 90s based on the advances in lathing the lenses in materials. And studies have shown that epithelial defects healed in all patients who failed bandage contact lenses, but recurred in about 89% when the scleral lenses were stopped, which indicates obviously they may need to be continued for a while, but healed again when they were resumed, and visual acuity improved in almost 90%. And then in a recently published case series by Witzberger, scleral lenses were found to be safe and effective treatment option for any stage of NK by preserving epithelial integrity and improving visual function. There's also been interest over the past decade or so in using neurotization Probably this is available mainly at academic centers, usually done by oculoplastic specialists who have experience doing it. The initial report was from Terzis and colleagues at Toronto Children's Hospital that reported improvement in corneal sensitivity, visual acuity, and corneal health in all 6 eyes treated with transfer of the contralateral supratrochlear or supraorbital nerves to the limbus of the eye with NK. That was kind of difficult sometimes to stretch the nerve like that. So there have been other options reported, both direct and indirect options for grafting onto those nerves, typically using either the sural nerve that's found in the back of the leg or the greater auricular nerve. And that's currently what our oculoplastic specialist is doing. One of our plastic specialists actually uses a preserved sural nerve, and then the other one actually harvests it himself. He thinks that the results are a little bit better with the fresh nerve. So someone that, again, has one of those conditions, it's never going to really improve. This is certainly an option. Like we've used it for patients with severe zoster with like virtually no corneal sensation or even peri-orbital sensation. This is a condition that sometimes you got to modify your therapy. So if the initial therapy leads to healing and stabilization, that's wonderful, and you can just press on with that. But if the patient is not healed or develops recurrence when the therapies are tapered, then you can restart with the initial therapy or consider modifying the therapy to one of the other options that I discussed. There are some new and emerging therapies in the works. Some of these are currently in clinical trials. One of those is thymosin beta-4, which is a peptide shown to promote wound healing and reduce inflammation. It's under investigation, as I mentioned, for NK and to enhance corneal repair and regeneration. Human mesenchymal secretome for persistent corneal epithelial defects, many of which have a component of NK, and then regenerative medicine approaches, including use of stem cells and matrix proteins that in animal models have been found to restore corneal innervation and function. So in summary, there's an increasing array of options for stabilizing and chronic supportive, protective, or restorative therapies. My recommendation is to plan initial stabilizing therapy to promote epithelial healing and suppress keratolysis, and then to add supportive, protective, and restorative therapies, especially for those conditions that are chronic. And the eyes with non-modifiable risk factors may require lifelong therapy. So we're going to go back to the clinical vignette and then have a test question. Again, this was a 70-year-old with trigeminal neuralgia treated with radiofrequency ablation. She developed an NK with an epithelial defect that reduced in size somewhat with a bandage contact lens and medical therapy, but didn't completely heal. And she was started on Synedgermin, and the epithelial defect has remained healed, and vision has improved. So if we go back to the question, what percentage of eyes treated with Synedgermin remain healed 1 year after treatment? And you can see, yes, the majority of you got the correct answer, which is greater than 90%. You may remember in my slide showing the results of the EU and the US trial, that the Bonini trial in the EU showed greater than 90% of the eyes remain healed at 1 year post Synedgermin treatment. To obtain your CME or CE certificate, you have to attend the webinar completely, and you'll be able to participate in a brief evaluation and download your certificate using a link displayed at the end of the program. This will also be emailed to you within 24 hours if you miss that. And please complete that by September 1st to obtain your certificate. We'd like to thank you all for attending and for your participation. And now we're going to open it up to panel discussion and questions from the participants. And I'm going to stop sharing my screen if I can.
Hey, Steve, that was a great presentation that you had. And, hearing about not just what is available now, but some of those future treatments. I mean, that's gonna be great because we need them. So please send any questions that you have in right now. We do have about 15 more minutes for everybody to get full credit. I always have questions for Steve, so I could ask him all. Actually, on that last patient that you had with the trigeminal surgery that they had, those are the patients that we all see. Well, not all the time, but those patients come in. So you said he was completely healed. What is your follow-up on those type of patients? Because we know they have a chronic condition. You didn't improve the surface, but when are you seeing those patients again from like the practice management standpoint? Is it 3 to 4 months? Is it 6 months or annually?
Yeah, that's a great question, Walter. Once they're healed, I tend to see them like at least for a couple of months every month, probably, and then maybe quarterly for a few times, and then I'll try to get them back to their referring docs. But I think the patients, once they've had that problem, they're pretty astute about knowing if they're starting to develop a recurrence, and they'll call back. And just like we both talked about in our cases, you can see recurrence despite the fact that these therapies are pretty effective.
So we have a couple questions here. So what can a comprehensive ophthalmologist do before referring, and how soon should we refer to you, Steve?
Well, I would say there's a lot of simple things you can do in the office, and one is just like Brian and I'm sorry, Walter and I said, treat their dry eye aggressively if they're stage 1, and even stage 2. Treating the dry eyes will certainly help. Consider bandage contact lenses. They're kind of underutilized but can be effective. And then amniotic membrane, which you can do in the office. And then if you're comfortable with it, consider maybe using the insulin drops that I mentioned. It's you just write a prescription for the patient to get a bottle of regular insulin. Unfortunately, the way that the FDA works, compounding pharmacies are not able to formulate topical insulin. It has to be done in the doctor's office. So I tell them to bring the bottle in, and then we make it with a bottle of BSS, and they can use that until they can get the other therapies like Synedrimin or PRP.
Can you go over that process again on how you formulate that? You mentioned earlier in your talk. Can you just repeat that?
Sure. Yeah. So I prescribe a regular insulin. It's Novolin R or Humulin R. It's really pretty cheap. As you may have heard, under the Biden administration, they got for Medicaid care patients, the price of regular insulin went down to $35 a bottle. So it doesn't cost a lot for those patients. Patients with commercial insurance, it may be a little bit more. And then I just tell them to bring that bottle in. It should be refrigerated to the clinic. And then we've even taught our technicians to do it. We withdraw. It's 100 units per ml. So I just withdraw 0.2 ml using a TB syringe and a 25 gauge needle, and then inject it into the bottle of the BSS. Shake it up. We label it with a date. I don't know if this is absolutely true because we haven't checked the stability, but we tell them that it's good for a month, and then to throw it out. So about once a month, they'll come while they're on it. They'll come back and we'll make another bottle for them.
Okay, that's great. I was busy writing that down because my partners Albert Chung and John Shepard and Liz Yu, we've been talking about implementing that within the practice, and so thanks for that. And so, yeah, Steve mentioned before you refer, there's different things that you can do first. Do the amniotic membranes, order the Synergimin. If you don't want to do it, there's people in your area that do a lot of it, and so just find those resources in your area. Another question is, would you use Synergimin and PRP drops simultaneously? I don't use PRP drops, but I will answer what I do with my patients that typically they've been on various dry medications. They may be on 2 to 6 different drops a day. But whenever we're doing Synergimin, it's 1 drop every 2 hours, 6 times a day for 8 weeks. And so it is the dedication that the patient needs to get their treatment, letting the patient know, hey, this is your condition. We've used these drops. They have not improved. Your surface is sick. Those cells are not working properly. That's why we're prescribing this medication. And so one drop every 2 hours, 6 times a day, 8 weeks. I say, if you want to do extra credit, you can, but you don't have to. The exception, well, I mean, that's essentially how I treat it. Steve, what do you do with the PRP drops and Synergimen?
Yeah, so generally, as I mentioned, if it's going to take a while to get Synergimen, or if it's not approved by their insurer, then I will go the PRP route. And obviously, it's out of pocket, but it's probably at a more affordable option. So I will have them use that, and then, but if I can get the Synergimen approved, I'll have them use that until they get the Synergimen, and then stop the serum or the PRP drop. And then, for if the great thing about Synergimen is, that the patients look a lot better and they often stay healed. But if they start to get punctate epitheliopathy again, then I might institute the serum or PRP after that, or even do another round of Synergimen if it's approved.
And that was one of my questions I was going to ask, because we both get this question, is how often do you refill Synergimen? Is it like, do you do it right away? Is it, hey, you've yet done it, we'll see, we'll follow, do whatever, maybe 6 months down the road, we'll do it again. What is your process in doing it, prescribing it again?
Yeah, it's that's a good question. It's both of those. It may be that after the 8 weeks they're almost healed. Like as I mentioned, the percentage of almost healing was slightly higher than completely healed in the trials. So then I might, if it's approved, I might just do another round right away if they're willing to use it 6 times a day for another 8 weeks, or even sometimes they cut back a little bit. And I've also had patients where they've been healed, and then they come back in a month or two, and then there's a breakdown again, and I've used it again. And often after the second or even third round, they stay healed. So you can certainly go 2 or 3 rounds if you can get it approved.
Yeah, but that still goes back to, our documentation is that we're testing for that sensitivity. You with your Coche Bonnet, me with my cotton wisp applicator with gloves on is reduced or absent. If patients need that, they have that persistent defect. I mean, that's what's available. That's on label. And so just working with the drug company who has their own resources that it's called Connect to Care. And so they work with the patient's insurance that you've already documented what stage that the patient has, previous treatments. So there's an application process that gets approved, or it goes through this company that's going to work with the insurance to get it approved. They'll be in contact with the patient, and then they ship that medication to the patient. So I've done the same. Had done refills for patients when they are needed. Can you explain neurotinization treatment a little bit more? When are you pulling that trigger? You mentioned it's mainly at academic centers. We don't do it in our area. Can you comment, Steve?
Yeah. So obviously it's a fairly big surgery. And when it works really well. I have had mixed results. I don't do it personally, but we have two of our plastics people that are interested and do it. So what it involves is like freeing up the nerve, generally on the opposite side, either the supraorbital or the infraorbital nerve. So they isolate the nerve, and then they actually split the nerve, and they graft on another nerve to it, the sural nerve, or postauricular nerve, because that's a longer piece. Initially, when they first reported it, they were actually running the nerve over through the skin down to the other eye. But obviously, you got to really stretch the nerve in that case to get it to go over. So using the nerve graft makes it a lot easier. So they tunnel through the skin to the other side, through the eyelid, and then they'll pull the nerve down through the conjunctiva, and then they split the nerve into multiple branches, and they wrap it around the limbus after the conj is taken down. And then almost always they'll do a tarsorrhaphy, sometimes a permanent one, which could be opened up later for about 3 to 6 months. So the patient has to be counseled that, they're not going to get any use out of that eye for a while. But like I said, when at the end of 6 months or when it works, it's great. I mean, they can get full corneal sensitivity back. But I have had mixed results with it.
Uh, any tips on getting scleral lenses approved as medically necessary for dry eye? In my clinic, we don't do scleral lenses. Anytime we have ocular surface disease patients, we do refer them out. I don't have any tips on that. Steve, do you?
Yeah, we have a huge scleral lens practice here with about 2 or 3 optometrists that pretty much do that. It's tough to get it covered. The only scleral lens that I know of that's actually covered, well, maybe there might be two actually, but the PROS device, which is made by the Boston Foundation for Sight, which unfortunately is only fit at select centers around the U.S. It's actually considered to be a prosthetic device, and they did that in a way so that insurance would cover it. Medicare actually fully covers the cost of the PROS device, but they don't cover for the fitting. So the patient's going to have to pay that out of pocket. Commercial insurance sometimes will pay for the device and the fitting. It depends. Sometimes we'll get the full amount, and other times it's a reduced amount. The other scleral lenses, unfortunately, except for maybe the iPrint Pro, may have a similar type of arrangement. They're not covered, but they're generally less expensive, so the patient will have to pay for it out of the pocket.
If there's any other questions, please set it in the Q&A box. I guess the last thing, another question that we can talk about in the last couple minutes, for a new dry eye patient, how long do you keep patients on, let's go back to stage one, how long do you keep them on the dry eye treatments? Or when do you say it's NK, and is it 1 month? Is it 6 months like my first patient I presented?
Um, they may need to be on forever. um, it just probably depends on their treatment response. But I would do it just like you did, for 3 to 6 months at the minimum, and then reevaluate. I honestly, I haven't kind of diligently retested corneal sensitivity after dry eye treatment. Have you done that, Walter, to see if that improves?
I have not. But so we mentioned steroids work. We know the immunomodulators work, and so we do give it time. But if it's not budging, let's say it looks exactly the same as last time, think NK, and then use the various treatments that Steve just mentioned. There's a quick question. If you've done NK, if you diagnose NK, do you prescribe Synergimin even without epithelial defects? And yes, we do. And so that's still going to go back to that stage one patient with that. It looks like dry eye. It sounds like dry eye, but it's just not getting any better. Test for corneal sensitivity. Is it normal, reduced, or absent? Reduced or absent, then you can order Synergimin. But typically, I'll do an amniotic membrane while waiting because it may take 3 to 4 weeks for the patient to get it. Steve does the topical insulin or the PRP drops within the practice. And so that's how we address that. So Steve, any final pearls that you want to give before we wrap things up?
No, I thought this was a great session, and I hope everyone got something out of it that they could take home and utilize in their practice. But thanks. It was a pleasure to do this with you, Walter, and I appreciate MedNet for sponsoring it, and Dompe also.
Well, thank you all for attending, and don't forget to follow up to get your certification as well. So thank you all.